A nice presentation. The last paper for this morning is by Dr. Phan from the Cerebrovascular Department of 115 People's Hospitals, Ho Chi Minh City in Vietnam. His paper will be on the organizational survey for acute stroke in Vietnam, a regional collaboration program in Australia, Vietnam, India, and England. RAVIE. Dr. Phan, please present your paper. Thank you.
The opportunity to present at the conference. I am Hoành Phan, who will be sharing with you about our research into stroke care in Vietnam as part of our collaboration program in Australia, Vietnam, India, and England. Stroke is a global issue, and the burden of stroke is much larger in low and middle income countries. Vietnam is one of the countries with the greatest number of deaths attributable to stroke. Stroke is the leading cause of death for men and women in Vietnam. The RAVIE program is led by Professor Dominique Cadillac from Monash University, and this is a workshop-based program including quality improvement activities funded by the Australian Academy of Science and Monash University. We have support from partners in the United Kingdom, India, and Vietnam as part of the Angel Program Vietnam. Within the program, we established a community of practice to improve evidence-based hospital care for acute stroke and use a data-driven approach to inform priorities, workshop content, and learning needs. Due to the global impact of COVID pandemic, we modified the program to include 3 virtual workshops for Vietnam, including pre-workshop electronic organizational survey. On the right-hand side, you can see our program leads that represent each of the countries and stakeholders. The organizational survey was designed to gain a better understanding of current practice and the resources available for acute stroke care in Vietnam. With permission from the Stroke Foundation Australia, we adapted the questions from the Australian Organisational Survey of Stroke Service to use for Vietnamese hospital. The original questionnaire was designed to identify potential barriers and enable us to provide best practice acute stroke care. It covers a broad range of hospital practices, as you can see here in this slide. Professor Dominique Cadillac and myself made the adaptations to the Vietnamese context with assistance from the 115 People's Hospital staff in Vietnam. I was also responsible for language translations of the question and back translations. The survey was distributed online to all hospitals that treat stroke in Vietnam. Participation rates were high, with 66 out of 91 public hospitals completing the survey. The survey was mostly completed by doctors. Population densities of provinces across Vietnam is depicted in the left map, with the darker regions demonstrating more densely populated regions. Location of the responding hospital to this survey are demonstrated on the right map, which are color-coded as green in the north, yellow in the central of Vietnam, and blue in the south, which cover approximately 76% of the population across the country. Most of the participant hospitals have an ICU, while 2/3 have a stroke unit. In this slide, about 1/3 of participants were working in stroke unit or stroke center, 24% from neurology department or ward, and 20% from emergency department. The number of patients admitted to the hospital last year varied between sites, with a median of 800 hospitalized patients to a ward and 400 to a stroke unit. The median number of beds each hospital was 850, with around 16 dedicating for stroke patients. In this slide, as we can see, more than 3/4 of respondents stated that stroke neurology team usually manage acute stroke patients. Nurse-patient ratio was 1 to 4 during the day and 1 to 12 at night, which is very close to the figures in Australia. Most respondents to the survey reported that the most likely first admission ward for people with stroke was admission ward or emergency department at their hospitals. These figures illustrate the capacity of the participant hospital in providing stroke care. Most sites have the capacity to provide intravenous thrombolysis, and half of them offer intravascular clot retrieval. About half of the hospitals responding to the survey providing rehab assessment, and about 2/3 of the hospital provided discharge care plan and training for carers in terms of rehabilitation to continue at home. And in these slides, about 90% of respondents stated that they have locally agreed protocols on managing fever, glucose, and swallow dysfunction. This was followed by the figure for the nutrition, hydration, and incontinence management. Most hospitals have data collection on quality of stroke care, and more than half of the hospital using the World Stroke Organization rescue. In summary, this is the first large-scale cross-sectional national view of stroke services in Vietnam. The next phase involves a clinical audit of stroke care to confirm aspects of the self-reported data from these hospitals. Project outcomes will inform whether tailored education or quality improvement program could improve stroke care quality in Vietnam. Thank you for your attention. Any query, please contact me via this email. Thank you.
Thank you for your very nice paper. Are there any questions from the audience? Thank you. Could you just share with us, you had quite a high response rate. About those who didn't respond, how were they different from the responders? Were they smaller hospitals? Were there fewer staff there? What is your understanding of the non-responders? Because 20+% is not a small number. Thank you.
Thank you for a very good, great question. So we send the online survey to all hospitals in Vietnam that treat stroke, and as part of our collaboration, we asked Angels Vietnam to support us to send reminder and provide support to the hospital that provide the response. And for non-response hospitals, mostly there's small hospital, and they didn't provide me with any feedback and reasons why they don't provide a response. So I would check, and thank you for the feedback. I think that I can figure it out to know about the I think that resources available from those non-response hospital and their scale of providing stroke services. Yeah, much appreciate that. Thank you. At this moment, I don't collect any characteristics from the non-response hospital.
Of course.
Yeah. Thank you.
Thank you so much. Any questions? Anybody else? Any other questions? If there are none, I think we can close session today. So thank you very much to all the speakers for your very, very nice papers. We enjoyed all of them. Congratulations for being platform presenters. Shows the quality of your work. I'll hand back to the chair of the session, Dr. Upal. Thank you.
Well, thank you, sir. The talks were really good.